Good evening, everyone. My name is Dimitri, and I'll be hosting tonight's webinar. In this instalment of the Rural Health webinar series, we'll explore common procedures required for the management of emergencies in a rural setting. Case scenarios will be used to illustrate how protocols, guidelines, and resources are used in the assessment, management, and transfer of patients in rural communities. Our presenter this evening is Dr. Anthony Wong. Dr. Wong is a GPA from West Gippsland in Victoria and is doing full-time anaesthetics. In his past life, Dr. Wong was a small-town rural GP with obstetrics in the Western District and one of the first GCCA graduates after his UK anaesthetics experience in the 1990s. Dr. Wong is involved in simulation teaching university students and has a special interest in human factors and ergonomics and self-care. I would like to introduce you all to Dr. Wong. Thank you.
Thanks, Dimitri, and thank you everyone out there in the World Wide Web for tuning in and spending your Thursday evening with us for the next hour or so. I'm talking about rural emergencies, and Dimitri asked us to put up a punchy line to reel you all in, and that's procedures, protocols, and people factors. Firstly, I'd like to provide acknowledgement of country. I'd like to begin by acknowledging the traditional owners of the land in which we virtually meet today. I'd also like to pay my respects to elders, past and present. And it's amazing that through this technology, we can meet from multiple lands. And I have the privilege of speaking from the Gunai-Kurnai land and waters. I don't know about all of you, but I'm enjoying being back in webinar mode, and I've got my pajamas on. And I think this is great that RSCGP is hosting this for people being able to tune in from everywhere in the warmth of their own home. Just some housekeeping. Basically, we've all been through the COVID times and done lots of Zooms. For me, I find using the chat function is a good way to engage with all of you out there, and I'll certainly be wanting to use that as part of this presentation. And I'd ask that the Q&A function be used towards the end when I can actually look at it, otherwise it interrupts the flow. And if you could post your questions at the end, that'd be great. This also gives us CPD points and an hour of CPD educational activities. Okay, so from the learning outcomes, by the end of this webinar, I'm hoping, or we're all hoping, that you'll be able to identify the common procedures and resources used to manage emergencies in a rural setting, otherwise known as the skills that are required, emergency skills. I'd like you to be able to discuss the protocols and guidelines which are out there that guide us in contemporary management, and in terms of the management and transfer of patients in rural communities. But I'd also like you to be able to discuss the people or the human factor elements required to manage these emergencies in a rural setting. So a bit about myself. As Dimitri said, I'm basically a rural practitioner. I started off as a small town rural GP in Terang in the Western District, and I did this for about 7 years. During that time, we had our own general practice. We had our 20-bed hospital. So having the privilege of doing the womb to tomb care and looking after inpatients, I did some obstetrics and also did some anaesthetics. Currently, I do full-time anaesthetics in West and Central Gippsland, Victoria, and my teaching role involves as a REST and ALS instructor for ACRM, as well as Monash undergraduate teaching, and particularly more rewarding is interdisciplinary teaching within our anaesthetic department and with our nurses. So what's relevant for this evening, and when Dimitri asked me to spend this Thursday night with you all, He mentioned an evaluation survey showed that rural GPs want more education on emergency medicine procedures, protocols and retrieval communication. So I thought, well, we could put all this together and they really intermarry each other. And the thing is, I understand where you're coming from. Even though I'm not a retrievalist, I have sent many patients away and transferred them out. With almost 30 years of transferring patients in a rural setting and a knowledge of the limitation of skill sets of the infrequent rural practitioner involved in halo events. And what are halo events? The high acuity, low occurrence events, where suddenly you're faced with an emergency situation that's time critical, but also illness critical, and you have to remember what you need to do. I want to share with you some of the useful resources I have found. And unfortunately, it's really only in Victoria, but I'm sure each state, and certainly we do pinch a lot of good information from other states. And just to simplify this and simplify the approach. Rightio, so let's have a case to warm up with. In Port Pirie, not Post Pirie, South Australia, you've got Fred. He's a 53-year-old local publican and he develops central chest pain. He collapses and is found unconscious. I thought the best way to demonstrate this is to actually use a demonstration video that I've accessed from the internet. However, this is one that I found really, really useful in my study and in my training. And I'd like to give full credit to the South Australian ambulance crew for this educational video. During this video, I will pause and discuss or even talk over them. And please let me know if you can't hear things. But I'd like you to start putting into the chat box what you can see as the relevant procedures or skill set that's required to manage this emergency, the protocols that we would use, such as the guidelines, especially the guidelines, and then think about also the people factors or the human factors involved that help make this resuscitation successful.
Ambulance! Ambulance! Can you hear me? Fred! Can you hear me? Fred, can you hear me? Fred! He's not breathing. Start CPR. Can you call for backup, please?
Okay, so our first procedural skills is effective CPR. This is where we're buying time, but also maintaining life. Effective CPR requires good hand positioning at 100 to 120 per minute. So we're using an aid like the metronome and compressing a third of the chest or 5 centimetres.
I'm safe. Okay. Shocking now.
At this point, they're using an AED, but another skill set that may be required is a manual defibrillator, especially in your hospitals. The manual defibrillator the advantage of that is less hands-off time and using an algorithm or a protocol of coached. Coached means continue compressions, oxygen away, all others away except for that person that's compressing, and charging. So all of this coach is designed to try and help us, first of all, have something to hang our hat on in a very stressful situation, have a structured way of approaching it, but also minimizing time off the chest. So charging while the person is doing compressions and then hands off to evaluate the rhythm. Once you've done that, we can then evaluate the rhythm into a shockable or non-shockable rhythm. And with a shockable rhythm, we defibrillate, but with a non-shockable rhythm, we need to disarm. And the important thing is that we need to do this safely. And you could see by this, by the people in here, by the responders in here, how they emphasise that, bonding it together with the people factors of good communication. So here we have another procedure that's required, which is giving oxygen. So we talk about 30 compressions to 2 breaths. Now it's quite tricky using a bag valve mask if you're not using it all the time. Even if you are using it all the time, that mask can easily slip off and the seal could be inefficient.
Rise and fall. Good rise and fall.
And you can see that there is actually time off the chest. So this is why I really love this video, because it actually demonstrates how a coordinated manoeuvre where she uses 2 hands to minimise any seal leak, and during the brief pause in compressions, she's minimising it by actually being the extra person to do the bag, to squeeze the bag. And this is especially the fact that there's only 2 of them here, which is one of the, I suppose, curses of working in a rural environment where we're actually personnel poor. And you can see how coordinated they are. So what she's also pulling out is a laryngeal mask airway, which is a second way of oxygenation, which will allow more freer hands. Again, this is a procedure that needs to be, that is important to be able to practice. And once this is, a protocol tells us that now we have a closed ventilatory system where we can just proceed with 10 breaths per minute without needing to pause and interrupt compressions.
26, 27, 28, 29, 30. Okay, continue compressions. 11, 12, 13, 14, 15.
So 2 minutes is usually the cycle where they'll analyse, and to maintain effective compressions, being a mechanical procedure, people get tired, and you can see how at this 2 minute mark they have trained that they will swap over so that someone fresh is maintaining effective compressions.
For the 54-year-old male with chest pain, 13, 14, 15. When we got here, it's in cardiac arrest. We commenced CPR. 30. Jenny, do you mind if I take the leadership role?
All right, so this is an important part of when help arrives and giving a handover. So one of our objectives tonight was retrieval communication, and we use a technique called isobar, which I'll delve into a bit more later. That's identification, discussing the situation, the background of the patient, the observations, and the events that have occurred, and then what are we going to do now? The other thing that she's doing is identifying herself as the leader. I suppose also the one who maintains situational awareness, who makes the decisions, who uses the standardised protocols, and guides or conducts the rest of the team.
Can you take over the airway management for me? Reggie, can you go and check home alone if there's any indication of medications or past history? Taking over airway.
So one of the important elements of the lead is, i.e. the people factors, is that she is hands-off. She doesn't do the physical activities. She's already quite cognitively overloaded with things, and she's cognitively offloading herself with using a checklist.
And Jenny, can you give me an approximate time for next shot, please?
Roughly about 30 seconds. Okay. So I wasn't able to find anything obvious in there.
Good CPR, Mel. We'll change again on our shot and charge. The metronome's on.
Yep.
Jen, you got a very good airway?
Yeah, had good input airway, rise and fall.
Okay. Reggie, could you check that any of the reservoir bags inflated?
Yes, all inflated.
and then check that the oxygen cylinder is still full. And if we have a replacement,
So the two minutes and a rotation to continue CPR immediately.
So, shocking now. Commence CPR.
So if you just listen to this in terms of her isobar presentation, or sorry, isobar retrieval communication.
I'm just going to call the EOC. Hi Andrew, this is Sonia. We're at Hometown A1, currently at a cardiac arrest. We're ambulance officers. We were called for chest pain, found a male patient in his early 50s, cardiac arrest. We commenced CPR. He's had a total of 4 shocks. We have an eye gel in situ, and he is currently in BF 829, just looking for some advice. Yep, we checked oxygenation. Mel Andrews suggesting that we transfer through the Hometown Hospital. Could you please go and get all the equipment required? Sure.
Great. Okay, so let's continue with our presentation. So if we could just put into the chat box, can we just summarize what are the important procedures are relevant to this scenario? Nothing as yet. Oops, I think I have started to muck things up a bit. Let's just get to where we are.
Sorry, Anthony. I've just been advised that the chat is disabled. So let me just go ahead and enable that.
Yep.
Apologies.
That's okay. Let's just get the share again going. Here we go. Everyone can see my screen?
Yep.
You there, Dimitri?
I am, yep.
Good.
So the chat should be working now.
Great. We missed all this technology, didn't we? Okay, so let's have a look. Okay, so we've got some questions here. Chat is disabled. Good, good. IV access. So if we can just talk about the procedures that might be relevant to this scenario. Okay, well, let me launch into it then. Procedures can be linked to, I think it's good to look at procedures and not get too overwhelmed and complicated by the detail of the procedures itself. With the BLS and ALS, we look at the overall objectives, which is the chain of survival. So early recognition and call for help. And our colleagues on the demonstration did that because it actually took a while for help to arrive. Early CPR, and as I said, that is to maintain life, keep perfusion of the brain and the heart and the kidneys, and to also buy time, while we look for one of the most common reversible factors, which is early defibrillation to restart the heart, and then moving into post-resuscitation care. So we could see how CPR, coached and defibrillation, recognition of a shockable and non-shockable rhythm, and post-resuscitation care, as well as basic airway skills, were important procedures and skills that are required. if your skill set in the past life or currently involved putting an arterial line or central line, there might be other procedures that could be important during this for this resuscitation. Would anyone like to talk about protocols that might be relevant to this? Well, the obvious protocol that we'll be looking at, or the obvious guidelines, is by the here we go, some chats here. The BLS or the ALS protocol, and intraosseous access is much faster than a CVC. Yep, certainly is, and that's a good point, that could be a procedure that you might be more comfortable with in this situation. And yeah, definitely the BLS or ALS protocol, which is along the doctor's ABCD approach. Thank you. I'll just move that over there. And there's also the transfer protocol. And I'd like to now direct you to another link that I found actually useful, and that's from the Ambulance Victoria. Let's have a look at it. Oops. Okay, let's have a look at this. So this is all on the web, and we'll have a link with the slides. So clinical practice guidelines, tap anywhere to begin. Boom. Adult, cardiac arrest. And here we have all the different types of cardiac arrests: medical, traumatic, also a discussion on ROSC management, withholding or ceasing resuscitation. Let's look at medical cardiac arrest, and we have a number of good important points. As with all things, such as cognitive aids, it's important to have looked at this prior to it all, rather than sort of at that time. Okay. And then finally, the people factors. And we've borrowed a lot of this information from our colleagues in the airline industry. It's important to call for help. I'd like to also get you guys to put in the chat function, in your experience, when you're looking at people or human factors or crisis resource management, which is all much the same, what have you identified as, say in this demonstration or in your own personal experience, as the important elements of an effective resuscitation? So I think declaring a crisis and calling for help is really important. There's a cognitive barrier that we often have of it can't be happening. I suppose a cognitive bias. This hardly ever happens. Intubating someone in the endoscopy suite, we've never done it, or it's only happened once in 10 years. So I know I often face that, and if the saturations are falling, well, it's probably a poor trace. Or you have a flat line on the ECG, well, the ECG is probably fallen off. So it's important to try and be mindful of that cognitive bias and declaring a crisis and calling for help early, especially in a deteriorated patient. Doesn't matter if it's wrong. It'll be right one day. Communication is really important, and communication is not just verbal; it's also non-verbal as well. And identifying the person and having a closed feedback loop. Coordination of the team, and you could certainly see in this demonstration the excellent coordination that was there. And this can only occur with practice and also a shared mental model, understanding what the actual the protocol is that's relevant to that scenario. Having a lead, but just as important is the team and coordinating all of this together. Decision making is another important thing, and I like to think of decision making as a spectrum between high acuity, low time. So in other words, you don't have much time and things are going bad very, very quickly, versus things are going bad, but there's more time to think. And so we rely on recognition-based reactions, following standard operating procedures during elements of crisis. And this can be transferred wide across the spectrum to our fire services, to our police services, to the army. Versus the time when things are relatively stable, almost a pause in the action, where you can move on to analytical or critical thinking to help with your decision making. And decision making means defining what the options are and acting, but also reviewing what those actions are. And then finally, anticipation and planning. And so in this scenario, that you could see how they anticipated what would happen next. So with each 2-minute cycle, whether it was going to be a shockable or non-shockable rhythm or return of spontaneous circulation. Right. Okay, so I'd like to now discuss a second case. In Moree, New South Wales, on a cold wintry night, James Donaldson is found wrapped around a tree in a single occupancy motor vehicle accident. He presents in a bad way with reduced consciousness, tachypnea, tachycardia, bruising to his left chest and hypotensive. The ambulance come and summarise that he's got possible head, chest and an obvious open fractured femur. Okay, we'll watch this video.
So Tracy, what do we got coming in?
Dr. Blair.
Forgive the Americanness of it, but I'd like you to particularly focus on this pre-briefing or pre-resuscitation.
Blood pressure is 90/40. He's got an obvious left femur fracture. They have him in a hair traction splint. He's backboarded, collared. They have him on some oxygen. It sounds like his O2 sats are in the 88 to 93%, and his GCS is placed.
So minimally responsive, and they've got some oxygen going.
They have oxygen.
One IV?
One IV, I think 18 in the right AC.
All right. So it sounds like this guy is pretty injured. We're going to need to take care of a lot of things. It sounds like he has an airway problem. It sounds like he's in shock. So a couple quick things we need to do very quickly when he gets here is let's make sure that we got our airway stuff ready to go. It sounds like you need to be intubated. So we got everything we need?
I got everything else.
All right. And Betsy, it sounds like he's only got one IV. So when he arrives, what I'd like you to do is put in the second IV in on his other side, if he doesn't have one. We'll get some blood out of that when we do it. Also, if you would call the lab an X-ray before he gets here, make sure.
So he's obviously sorted himself out as the lead, but then he's allocated his team and given them jobs. And he's looking at the equipment and making sure that that's all organised.
The other thing think about is this guy's probably bleeding a fair amount from the sounds of it. So let's notify the blood bank. And let's get the
just basically giving them heads up and bringing them together with a shared mental model of how they're going to approach this.
For us to keep here. So once we figure out what's going on, let's get the trauma center on the phone because I'd like to talk to them and get him transferred. Okay?
Yes, sir.
Okay. Any questions?
Oh,
All right, let's do it.
This is Garrett. He's 18 years old. He's an unrestrained driver in a single vehicle MVA into a tree. About 10-minute extrication. He has a GCS of about 8. Has a head injury up here underneath the gauze and has an open femur fracture with some minor bleeding.
Is it motor vehicle collision into a tree?
Yes.
Prolonged extrication.
10 minutes.
He's unrestrained.
Unrestrained.
And you said he's got an obvious head injury
Obvious head injury.
and an obvious femur fracture.
Open femur fracture with some
Okay,
bleeding.
and that's all you see right now.
The bruising to the left chest as well.
And his last set of vitals.
Blood pressure is 90 by pound. He was 120 times tap on the monitor. Respiratory rate is about 12. He's clear bilaterally. And he's an unresponsive for us.
Any other issues?
Not that I know of.
All right, thank you very much.
Thank you.
All right, guys, this guy looks like he's got a lot of injuries, and let's do this in a nice systematic fashion. We'll start with the ABCs.
So when he's talking about a systematic fashion, he's talking about a structured approach of the primary survey with a doctor's ABCD approach. They've already done the danger part in terms of personal protective equipment, checking for response, and that already gives a ballpark of where they are at in terms of the triaging and the what danger the patient is in.
Well, if you say that's 82%, so we're going to need to intubate him. So what I would like you to do...
Dealing with the airway
is,
first,
I want you to
and
put
our first
C-spine
procedure
across
being
here. Take the
intubation.
C-spine collar off.
Now, this may not be in your
Put
skill
in
set.
oral airway in
The
here.
most important thing
You
is
can get a little bit
oxygenation,
there, all
and we
right?
can delve into that
Oral
a
airway
bit later
in. Go ahead
in the
bag
question
here.
and answer section.
Responsive. It looks like he's going to need to be intubated. Do we have our
He's
intubation
pre-oxygenating,
He's right behind you, ready to go.
All
ready
right, can you bag him
to
here while I grab
intubate,
him?
and that's our first
Can you come off for a
procedure.
second?
So obviously
Take a
he
look
feels
here.
confident,
Looks like we got a little bit of blood
competent,
in there. Suck that out. All
if
right.
not credentialed,
Suction.
to
All right,
intubate.
good. Great. All right, let me just take a peek here.
Let me know if you want some criteria.
She's maintaining cervical spine immobilization because we don't know whether he's
Going in. Great.
injured his cervical spine. He's attached to what we call a capnograph, and when we teach,
So Tracy, what
what's
we
up,
got
sorry,
today?
Blood pressure is 95.
Here on this side, help me with the airway in here. Looks like we got a little bit of blood in there. Let me suck that out. All right. Suction. These cords, tubes going in. Great.
when we teach skills or procedures, I like to talk about preparation, procedure, and then post-checks. And one of the post-checks of intubation is to check that it's gone into the right hole, and that's using a capnograph.
All right. And let me take a listen to his lungs.
And checking it hasn't gone down into the right main bronchus, and that's why he's having a listen. Now he's moving on to breathing assessment, where you inspect, palpate, percuss, auscultate, look at their rate of breathing, oxygen saturations.
Intubated, his pulse ox has come up to 96%. What are our vital signs doing?
Looks like his heart rate's 115 and his blood pressure is 90/40.
All right, so it looks like he's a little bit in shock. We've got airway and breathing taken care of. Is he bleeding anywhere actively? So he's bleeding down here on the leg. Can we get some more help? Hey, Will, can you help us?
Where would you like a second IV?
Yes, let's start a second large bore IV, and we'll say normal saline. And how much IV is hopefully, put some pressure on that if you would, please. You keep bagging. Start a second IV over here, Tracy, if you would. And I think this guy's going to need some blood, so let's call the blood bank and get a massive transfusion protocol going. All right?
So massive transfusion protocol, it's really a call for help and asking that they provide lots of blood and blood products.
Big pulses here with some bleeding there. It looks like an open femur fracture. I don't see any obvious bleeding on his chest. His abdomen is soft. His pelvis is not stable. I think he's got a pelvic fracture, so you could have significant bleeding from there. So definitely this guy's going to need some blood, so let's make sure we get some blood products for him. In the meantime, let's expose the patient. Does that bleeding seem to be taken care of there? Did you wrap that, Will? Yep, let's read it out. All right, can you go ahead and give him...
So an added procedure here would be intravenous access, or as someone mentioned, intraosseous access, if after 2 attempts or 90 seconds you're unable to establish intravenous access. We're given the permission in guidelines and protocols to get out the drill and establish intraosseous access. He's now doing a formal Glasgow Coma scale.
He's got a significant head injury, and we're going to need to get him to a neurosurgeon. In the meantime, let's keep oxygenating him. What's his blood pressure doing now? Looks like, let's see, it's up to 105 systolic. Heart rate's down to 100. We also, I think we're going to need to wrap this pelvis with a sheet. Can you grab a sheet for me there, Will? Let's go ahead and make sure...
There are 4 sources of major blood loss, being the hemopneumothorax, or the chest, being the abdomen, the pelvis, and the long bones.
All right.
And this chap has already has suspicious 2 out of the 4.
2 and 3.
All right, let me get this backboard out. And I'm going to examine the spine here to make sure...
So he's now moved down to E, which is exposure. But all these acronyms can be used for different things. E could involve environment. It could also mean everything else.
Well, I've got him up here on the side. Let's put the x-ray plates in to get a chest and a pelvic x-ray. All right. And let's bring it back on your count again.
Ready? 1, 2, and 3.
Can we call for x-ray, please? chest and a pelvis. Yes, sir. All right, guys, let's reassess what we've done so far. We've done our ABCs. We've got him control, airway control.
Reassessment is an important part of primary survey and resuscitation, and dealing with each of the letters in order.
He's got good pulses. He's also got some bleeding from his scalp and an obvious head injury. So this guy, clearly we need to transfer him to a trauma center. So what I'd like to do at this juncture is we'll take a look at those x-rays we shot. I want you to put an OG tube in because of concern for a head injury, and I want you to put a Foley catheter in a moment here. And then what we'll do is reassess the patient. What are his vital signs right now?
Currently, his O2 sat is 96%. His blood pressure is 110/64. Heart rate is 97.
And this is what I mean, like a relatively stable part where he can move now on to more analytical and critical thinking about everything that he needs to do.
We're going to get him packaged up for the trauma center. So Betsy, could you get the trauma center on the phone for me? I need to talk to them and arrange transport. And while we're doing that, we're going to do a detailed secondary survey. We're going to do a head-to-toe, fingers and tubes in every orifice exam. We'll get him all packaged up to go. And also, Betsy, could you make sure that the X-ray department makes copies of all of our X-rays so we can send them along? Tracy, it looks like we've got our X-rays back. We've got a chest here. Looks like he's got some rib fractures here on the left side and some haziness. He's probably got a pulmonary contusion. And his pelvic film, he's got a acetabular fracture, a pelvic fracture. That confirms, I think, what we think is going on with his blood loss. Let's get copies of these X-rays made and send them so we can send them on to the next hospital with him, okay? Dr. Brazell, hi, this is Mark Boyer.
So retrieval communication.
That I need to transfer you to you. It's a 18-year-old young male who was involved in a high-speed motor vehicle collision. He ran his car off the road into a tree. There was significant damage to the front end of the car. He was unrestrained. Apparently, he was unresponsive at the scene. We intubated him. He does have some diminished breath sounds on the left side with some rib fractures, and he's also got what appears to be a pulmonary contusion. He's also got bleeding from a scalp wound. He's got an open femur fracture on the left side. We've immobilized it. He's also got a pelvic fracture. We've got him in a pelvic sling right now. We've given him 2 liters of fluid. He's got 2 units of blood. His blood pressure right now is 110/50. His heart rate is 110. And we've got him intubated on 100% oxygen with 98% saturation. Yeah, I think that he probably needs to come by air. So if we can make the arrangements to send the helicopter, I'd appreciate it. And I will package him up. I'll send some blood.
Okay, so let's look at the people factors here. And I'm reversing it around now to see how, to try and demonstrate how using the different subsets can help manage this very complex situation and really sort of break it down. People factor started off in the beginning with I suppose a pre-resuscitation brief. If you do have the time, they were obviously very comfortable and familiar with each other. And again, it was calling for help early, and in many centres now we have video linkage to tertiary centres and tertiary trauma centres such as the Alfred Hospital. He was clearly the leader in this, but at the same time, he may need to pass the baton to the senior nurse as he becomes task focused with certain procedures, such as intubating. And that's why he asked, please let me know when those SATs are changing or falling. Establishing the role clarity, distributing the workload, and it's really important during these times that even though our communication may be clear, that we don't over-distribute the workload to certain team members that you may feel more comfortable with. Communicating effectively, and again, it's using your requests and commands very clearly, but also very simply. We're all heightened with stress, our stress reaction, and during that time, our vision, our hearing, and our thinking becomes impaired. So it's important to try and be mindful of this when we're communicating using simple commands, but also having feedback loop closed communication and avoiding the thin air statements. Anticipating and planning, and that's certainly what they did in the pre-brief and the pre-resuscitation phase. Knowing their environment, and you noticed how she said, oh, the equipment is behind you, or the intubation equipment is behind you. Using all available information, and you saw how they kept centering in on or referring back to the vital signs, the monitors, and that would set the tempo and the pace of the condition of the patient. And allocating attention wisely, and that's in that structured approach of a DRS, A, B, C, D and E approach of the primary survey. Mobilising all these resources, and you saw how he was quite resourceful, I suppose, when he was examining the back to then put the X-rays, X-ray cartridges down, and using cognitive aids. And we certainly saw this more in the first scenario. And these cognitive aids, it's important to be familiar with their content, format, and location, and how to find them, and also practice using them. I want to introduce you to a nice model called Step Up. Now, Step Up is otherwise known as the 0-point survey, or what we can do to help prepare for the resuscitation prior to and to allow for success for the resuscitative phase itself. First thing is a self-check, and that's mental readiness and physical readiness. That's getting ourselves together and getting ourselves in the right headspace for this. We talk about the team and the clarity of and role clarity, and we talk about the environment as well. Having good space, clearing out unnecessary clutter, clearing out unnecessary people for crowd control, minimising the noise as our volume turns up or people talk as they're getting stressed, optimising the light and having all the equipment available. Then comes the patient, and this is where we launch into our primary survey with an A to E approach. Getting a quick clinical history, and that's where we deviate from our normal history of presenting complaint, past history and so forth. And we can use a useful acronym called AMPLE, which is allergies, medications, past medical history, last meal, and events coming up to the procedure. At this point, it's important to then move on to update, and you could see he gave a brief summary as he reviewed where he was at or with the team, and having a shared mental model of their status. And then establishing the priorities. Is it a primary airway problem, a breathing problem, or a circulation problem? And re-looping as necessary. So we have the lead, team and role allocations cemented by good communication and decision making, and the flow is assisted by anticipation and planning and prior preparation. So when we talk about the step-up approach, self-management, we use an acronym called I'm Safe, which is what actually the airline pilots use in terms of prior to as their pre-flight checklist. Any illnesses that are going on, any medications that they're on, any sleep issues, any alcohol and drug issues, any fatigue issues, and any emotional issues. One of the major barriers to working effectively can be summarised as HALTs, if we're hungry, angry, late, tired, stressed. So pre-resuscitation may mean getting a quick bite to eat, having a Mars bar or a Snickers bar, going to the toilet, but also getting yourself fully PPE'd and in the right space. There's a lot of self-management tools such as deep breathing, talking, positive talking to yourself, and also slowing down, with a favourite saying in the armed forces of slow is smooth, smooth is fast. Getting your team prepared and establishing a clear lead who is not cognitively overloaded and is able to stand back, as well as the team members who all know their tasks and are comfortable with their tasks, having the equipment available. Now, in a trauma approach, and we can certainly discuss some of the things that could have been done better in that demonstration, we often have a C, doctor's ABCD approach, and that's protocolized. C means compressing any obvious bleeding, external bleeders. And so perhaps that open fracture could have had some compression a bit earlier. Checking for dangers, response, and sending for help. And as I said, response gives you a ballpark figure as to the triage category of this patient. And assessing the airway with protection of the cervical spine. And that's paramount because you can't go any further until that gets sorted. Now, some of us may not have the skill set of being able to confidently intubate. However, they might be able to have the skill set or the procedural skills of being able to put a laryngeal mask, and that's perfectly fine. Checking for breathing, and in trauma, I always think of, I need to make sure before I leave breathing that 5 important conditions are excluded, i.e. tension pneumothorax, a hemopneumothorax, an open pneumothorax, a flail chest, and cardiac tamponade. With the circulation, anything causing circulatory embarrassment, and the 4 big areas that can bleed. Disability, I'm not clever enough for the Glasgow Coma scale, but I use an AVPU scale, being alert if they're alert, responding to vocal stimuli, painful stimuli, or they're unconscious. And if they're in the PU, then their Glasgow Coma scale is less than 8, and their airway is at significant risk of closing over and is unprotected. And E, as I said, could mean exposure. The other parts of D can be expanded into, don't ever forget, the dextrose part, as well as drugs. And the other part of E can be expanded to exposure, environment, or everything else that you might have forgotten. U is updating, and P is priorities. Is it an airway problem, a breathing problem, a circulatory problem, or a disability problem, or a combination of each? This is a nice model that I like to sort of explore as well. And maintaining situational awareness is really important, and that helps with our decision making. I discussed that the decision making may vary depending on the situation, is that if you've got low time or high time, as in a critical situation, and we rely on recognition of pre-assessed or pre-seen things, or i.e. recognition-based reactions, or reacting to with standard operating procedures or protocols or guidelines that are out there that we can pull out and then just do while we're hopefully moving into more analytical and critical thinking. There's also the importance of communication and teamwork, and I hope I've demonstrated this quite well in the 2 scenarios, as well as clear leadership. And all this is bonded by good attitude, skills, knowledge, and performance of your team. Okay. And now procedures. I'd like to just share with you another link called Emergency Procedures. And again, this is widely available on the internet. And if we click on that, and I'll demonstrate that to you, it's divided up nicely into airway, breathing, circulation. And in this particular case, we may look at airway opening maneuvers. We may then look at rapid sequence intubation. And if we can't intubate or get it, and we may look at putting a laryngeal mask airway in. Breathing, this patient may need an open thoracostomy. And circulation, they may need a central line or an arterial line, and certainly the intraosseous access. And this, I'll just show you, let's have a look at the breathing, and let's have a look at the thoracostomy, and I'll just give you a demonstration of what the potential, and this is all free on the internet.
In the 4th to 5th intercostal space, anterior to mid-axillary line. Two rapid ways to do this is with the arm by the side, mark the anterior mid-arm point from shoulder tip to antecubital fossa, or place your open hand in the axilla and mark the edge of the hand between the anterior and mid-axillary line. Anesthetize the skin, soft tissue muscle with the upper border of the rib. Push the clamp through the muscle to open the clamp slightly with possible hiss or gush of blood. Rub the clamp from side to side on the superior margin.
Okay. And then protocols. Now, this is another useful website in Victoria again only, and the major trauma guidelines. And this is the covering page. And then from this, you may click on thoracic trauma, and it gives you a nice one-pager infographics. And that's certainly what I've found during the COVID times, the guidelines that were coming out, the infographics were especially powerful. So obviously these are some useful sites and references that we can you can explore and look at during your leisure, but at least be comfortable with it prior to the event happening. And finally, the clinical practice guidelines, which I've already shown you, where we can look at different aspects and elements of emergency care that the ambulance have put up. So finally, it's all about communication. And the communication in terms of transferring these patients out is fairly standardised with an ISABAR approach, which is introducing yourself as well as identifying the patient, stating the immediate clinical situation. And it's quite interesting. A dear friend of mine once said, who's been experienced in transfers, she always said, have your spiel ready. Because everything is recorded. This patient and her condition has got high demands that is outsourced, that is beyond the capacity of our institution here or of our hospital here, and that will get you some help very, very quickly. Give the relevant background and clinical history as succinctly as possible, and work through an A to G assessment or A to F assessment. And then summarize where you're at, and then ask for the recommendations and what we should be doing now, or what you want them to do next. Okay, so we're coming to the end now, and in summary, tonight via 2 rural emergency cases, we've explored the procedural elements or the skill sets required to manage these cases, ranging from the deteriorated patient and being able to give effective CPR to the deteriorating multi-trauma patient with potential for A, B or C intervention. The importance of sort of a structured approach dealing with each of those priorities. We've looked at some of the protocols that may help guide us in their management, such as immediate decision making using standard operating procedures, from the ALS guidelines to Victoria trauma guidelines, and communication of the transfer of these critical ill patients in a nice systematic fashion, a common language via ISABAR. And finally, we've looked into the people or human factor elements that underpin and cement all of this together, ranging from early call of help, declaring a crisis, to clear communication, coordination and team management, and having good decision making, anticipation and planning. So I'd like to open to any questions, please.
See if anyone's got a question or even a comment for Anthony. Now will be the time. Okay, they might come in. Oh, I think there's a couple of comments that have come through the chat and a question.
So I might just stop the share If you want to just quickly talk about this, and then I can stop the share and might be able to have a look at the questions.
Oh, okay. Yeah, very good. Yes, so thank you so much, Anthony. So I would like to invite everyone today really to sort of attend our upcoming online emergency medicine workshop, which is scheduled on Saturday, the 10th of August. So this is sort of a great way to sort of reinforce some of the points that Anthony has addressed this evening. It's a small group online learning experience, which means that you'll rotate through a series of 4 different cases, and each case will have an expert facilitator that will guide those discussions. So yeah, we'd love to see you there. Feel free to scan the QR code on your screen. I'll also include more information about the workshop and the registration link just in the chat box as well. At the end of this webinar as well, an evaluation will pop up, so feel free to complete that. And CPD hours will automatically be uploaded tomorrow for everyone that's attended. For non-RACGP members, if you would like a certificate, just please email rule@racgp.org.au.
So
Thanks, Anthony.
let's have a look at some of these questions and the comments. Sorry. Good. So, okay, so what have we got? Can you show me the emergency procedures website again, please? Sure. How about we go into that in a sec? So in the trauma case, wouldn't a fast scan, in addition to the pelvic x-ray, be more specific for abdominal bleeding? Definitely, if you can do a fast scan and if your ultrasound is available. And it's certainly part of the practice and the training of emergency department doctors at the moment. Definitely can have the slides or links emailed to you. Clear communication. I think you were all just answering my questions beforehand. Great. And I'm sorry, I actually couldn't see this because I had it all in the share. But thank you for responding anyway. So let's have the Q&As. Oropharyngeal airway insertion. Right. Okay, so I'll just share the screen and we can look through the emergency procedures website again. So if you look on, here we are. So that's it's basically emergency procedures. Just Google that and you'll find that, and you can look at airway, breathing, circulation, and it runs through burns and immobilization, and it can run through each of the different procedures and skills that are required and give you tutorial. It's really challenging teaching emergency medicine in that I do these courses really to keep myself updated, and I think the basic fact of the matter is that we don't do this very often. Obviously I deal with airways as my bread and butter. However, putting in a chest tube, doing a surgical airway, and that's why it is rare. And that's why we train for this. We do this repeatedly. However, there's a natural forgetting rate. And my tips with going to these courses to learn these procedures is to break it down into preparation, which often means knowing the anatomy and optimizing the position for success. So for example, putting in an endotracheal tube is putting them in an optimal airway position. So you can learn these little tips and tricks from the instructors. Then there's the actual procedure, and I like to try and break the procedure down into 3 or 5 steps, which are very easy to remember or to record down. and then the post-procedural checks to make sure that the procedure that you've done has been successful. And then other ways of consolidating this skill is obviously practicing it or mentally rehearsing it as well.
Sorry, Anthony, there's just a couple of questions that have come through. If you like, I can read them out
Yeah, it
if
might be
you
better,
can't
easier
see
to
it.
work there.
Yeah,
I'll just
sure.
keep like this.
So for the trauma case in ED, one, is a blood coagulation test useful during a citrate tube? And two, would a DEXA scan be useful for lower limb problems?
Using a blood coagulation, these days we use more advanced thromboelastography. That may not be available, so it depends on what's available in your institution. So the using a blood, putting in a citrate tube, I have heard of that being done. However, I think my preferred approach would be to assume that there is a coagulopathy and to replace like with like. So if they're for example, the best way to explain this is I work in a rural hospital that deals with a lot of obstetric patients, and hence there is a risk of catastrophic obstetric hemorrhage. We would institute our massive transfusion protocol, but we would ideally have advanced clotting determination measures such as thromboelastography, and we've certainly toyed with this. But this more advanced technology requires skills and upskilling and procedural and protocolized approaches. However, we've decided that probably the better, more practical approach is what we call is an estimation. So, for example, I would say that if you're giving 2 units of packed red blood cells and you're needing to give more, then we're going to start having a coagulopathy, and we need to start giving added coagulation factors in a specific ratio, and then do the bloods, which may or may not be available, but they'll always be late.
Yeah. There was another question as well about the role of LP in emergency case of subarachnoid hemorrhage. Is there any time limit? Not too sure if you need further clarification.
Yeah, I'm probably not the best person to answer that because I don't work in the emergency department as a regular rule, and I'm sure there are more up-to-date people that can answer that.
Yeah. Thank you. And in terms of the the emergency procedures webpage, Marinta can't access it. Is it an app rather than a webpage? Do you know, Anthony?
I've got it up here.
Yeah.
So, do you want me to try and Google it?
Yeah, if you can.
I'll just. Yeah,
Is it? Yeah, it could be. Could be a browser thing as well. While you're doing that, I think Sally's just also added a comment. Working in a small rural urgent care, resources are slim with no radiology available. Point of care blood testing only. Requires skilled assessment skills and managing basics.
Sorry, I'm not very good at multi-skilling.
Okay.
So what would you...
I think that was more just a comment, so I just thought
Yep,
I'd read that out to you.
So this Life in the Fast Lane is very useful, and this is where I accessed most of the thing. And yeah, as you say, there's an app as well for the emergency procedures.
Yeah. And just before we're done for the evening, there was also a question a little earlier on. In the trauma case, Anthony, wouldn't a fast scan in addition to the pelvic x-ray be more specific for abdominal bleeding?
Yes, yes, most likely, because as I said, that uh, trauma demonstration I think was pretty old, and these days is the fast scan has superseded a lot of the emergency as part of the primary survey. But that requires someone who is able to use a fast scan proficiently and interpret the results effectively.
Fantastic as well. And just one last comment there. So Sarah Ferguson can't access it either. There are various other online similar website. I was going to say Life in the Fast Lane is very good.
Yeah,
Um,
that's great.
yeah.
Yeah, I'll find them a really good resource.
Great. Well, again, Anthony, thank you so much for sharing your experience and your knowledge and your wisdom. I'm sure everyone, including myself, got a lot out of that 1 hour. Thank you all of our attendees for coming along. Again, if you've got any questions, feel free to email the rural faculty at rural@racgp.org.au. We look forward to welcoming you to our next webinar, which is on the first Thursday of September, which is the 5th of September. And that topic's going to be slightly different to this one. It's glucose controlled, the use of controlled glucose monitoring and the outcomes on diabetes care management. So we look forward to seeing you all there. And on that note, I'll end the webinar for everyone. Have a great night. Thanks, Anthony.
Great, thank you.
Bye-bye.
Bye.